Hello, everyone. So I'm going to tell you about the post-TB SIG project on medium and long-term post-TB sequelae in sub-Saharan Africa. TB is an infectious disease affecting the lungs. As we all know, however, every year, WHO estimates that there are 10.8 million new cases of TB, more than 1 million people dying from TB. 25% of cases of these cases are reported in Africa, or were in 2023, and this affects mainly the young adults in developing countries, people between 25 to 45 years of age. Now, these are chest X-rays of 2 patients who have completed treatment and considered to be cured according to WHO's guidelines, recommendations. You can see that both lungs are normal here at the top. Probably someone who benefited from early diagnosis and treatment. However, in the second patient, just 1 lung is still functional after treatment. It's probably someone who was diagnosed late with an immune response, host pathogen interaction with excessive inflammatory response. And this led to lesions and damages, important lung lesions, and post-TB sequelae. So it means that even if you treat someone successfully, it doesn't mean that the patient can recover completely. And these patients may present with post-TB sequelae. And this gives me a cue to give you an introduction on post-TB lung disease, PTLD, as they are called, these diseases, and their impact on quality of life. One patient in 50 worldwide has been treated for TB, on top of which you should consider that some 50% of people treated for TB will present with or develop sequelae, and with chronic diseases, acute infection, and of course this does impact their quality of life. So this acute infection has become a chronic disease in many parts of the world. There are very few prospective data on PTLD, especially in Africa. And as far as we know, there's no data on the medium and long-term PTLD burden and their impact on quality of life. Now, the post-TB SIG project, of which I'm one of the main sponsors, aims at estimating the medium long-term burden of PTLD after the end of TB treatment. We also want to study the association between the presence of PTLD and the poor health-related quality of life in the medium and long term in people who have been treated for TB in sub-Saharan Africa, to identify factors associated with PTLD after TB treatment. Also describe the care pathway, and also evaluate the impact of PR, pulmonary rehabilitation program, in terms of improving respiratory function and also improving quality of life. I'm going to show you results in link with the 3 first objectives. In order to meet these objectives, we do have a cohort based on former clinical trials that were conducted in Africa some years ago, some 20 years ago. And in those clinical trials, the TB patients clinically confirmed in the laboratory were treated like Ofloturb, Rifavirenz, Rifashort, and they were conducted mainly in Uganda, Benin, and Guinea. And we wanted to look for these patients, to call them and perform a thorough assessment, a clinical assessment, also lung assessment, to look for PTLD. Once we had located those patients and their informed consent obtained, they were subjected to a clinical examination. We looked for their history, medical history over the past 20 years. We also assessed their respiratory function with spirometry, 6-minute walking test, chest X-rays, CT scan for some of them, depending on the criteria. Quality of life was assessed with 2 standardized questionnaires I'll mention later. Now, let's review the definitions. PTLD, in our definition, is the presence of pulmonary functional impairment on spirometry data, according to the latest lung function initiative guidelines. This helps you to identify obstructive or restrictive or mixed ventilatory disorder and or the presence of symptomatic bronchiectasis symptoms confirmed by CT scan. The 2 questionnaires that were used were firstly the St. George's Respiratory Questionnaire, or SGRQ, which is quite specific for respiratory disorders, looking at 3 domains, 3 areas: symptom frequency and severity, also physical activity limitations, and also psychosocial consequences and their impact on quality of life. If you're above 10, well, it means the quality of life is severely impaired. The second one is the SF-36. It's more general, and if you are above 62, the quality of life is also considered to be impaired. And also we looked more precisely for the impact on current health and also what sort of impact on the outlook and resistance to illness. Now, let me share with you the preliminary analysis of the results. Following our search, 204 participants could be included out of 322 in Uganda. In Guinea, 360 could be included out of 1,100, and in Benin, 122 out of 528 patients could be included. 30 to 50% of those participants couldn't be contacted. We could not locate them during our inquiry. And noteworthy, the death rate, mortality rate is quite high. As we could see, we could observe during our this preliminary phase, and a lot of these patients were co-infected with HIV and TB. So the mortality rate is quite high for those patients 10 years down the road after treatment. In total, 686 participants could be included in our study. And now let's take a look at the characteristics in the medium and long term of PTLD. 21.5% of individuals were presented with ventilatory disorder, 25% restrictive disorder, 8.2 mixed, 14% bronchiectasis, and so in total, 56% of them with PTLD. And among them, 34% presented with severe decrease of forced expiratory FEV in 1 second, so FEV1 under 2.5 Z-score, which is in itself something that makes you eligible for a rehabilitation program. The characteristics, depending on PTLD or a lack of PTLD in the participants. Well, let's start with the time to our assessment, between end of TB treatment and our assessment. The median time is 11 years. However, the column with more than 10 years corresponds to more than half of the participants. The median age was 43 in all three countries. More male patients, 75%. 35% of these participants were co-infected with HIV, and 11% diabetes. Alcohol abuse was reported in 17% of participants. Smoking was significantly associated with PTLD, and 12% of these participants were declared the use of coal, and 57% the household biomass combustion. It's a univariate analysis. In the same chart, quality of life results on SGRQ shows that the median score is much higher in patients with PTLD. The median score is 10, therefore associated with a major impairment and deterioration of quality of life because of PTLD, because of post-TB sequelae, which is not the case, which we could not observe or did identify on the SF36 return. And there is also this link with the presence of post-TB sequelae. Clinically, PTLD participants are more symptomatic versus the other participants, and hemoptysis, in particular coughing, also poor exercise tolerance. In conclusion, despite the limitations or likely limitations in terms of representativity of initial clinical trial population, our study allowed a rapid assessment and a thorough assessment of medium and long-term PTLD burden in this region. We could show that within 2 to 20 years, PTLD is highly common in sub-Saharan Africa, and it's also associated with a severe deterioration of quality of life. There is also high mortality of TB, HIV patients 10 years after treatment, and poor HRQOL more prominent among those with PTLD. The outlooks, we think that we need to reinforce early TB diagnosis. We need also to allow these people to get access to pulmonary rehabilitation programs, is to restore their functional capacity and improve their quality of life, as is already the case for the congestive obstructive bronchopathy. And there's also some need for research on host-directed therapies to better modulate the immune response and to avoid the hyper-responsiveness that leads to the damage of lungs. I'd like to thank all participants and also the study team in Conakry in the 3 countries where we conducted the study.
Merci beaucoup, Gino.
Thank you very much,
Okay,
Jean.